We are live, sir.
Good evening, friends. Welcome to all the members of Indian Arthroscopy Society. At the outset, I must congratulate and welcome the new incumbent team of Indian Arthroscopy Society Executive Committee. We have new dynamic young members joining in after elections, and this is the first academic event which we are conducting online. This one is a brainchild of our new incumbent secretary of Indian Arthroscopy Society, Dr. Sundararajan. IAS Academic Corner, it's once in a month meeting. It would be held every second Saturday between 8 and 9. And it is it's a one in a new kind of concept where we have 3 presentations, one by a master surgeon and 2 case presentations, and followed by discussion. I think this would be a very good platform for young people to join in, present their cases, and share their knowledge with other members of Indian Arthroscopy Society. I request Dr. Sundararajan to kindly introduce the panelists, the faculty, for this inaugural first Academic Corner meeting today. Sundar, please.
Thank you, IPS. And also I thank all other EC members of IAS for agreeing this kind of platform, because it is going to help for both senior faculty as well as all the young surgeons to showcase their talent. And the outset, I would like to thank Dr. Rajan sir for accepting my invitation to moderate this first session. So it's a great honor for us to have Rajan sir. And also to moderate, I invited Dr. Swarnendu Samanta, who was the first secretary, dynamic, and he did a very good programs in the last 2 years. So Samanta is going to moderate these sessions too.
Thank you, Sundar.
At the same time, I like to thank Dr. Sachin for accepting this invitation. He's our close friend and also is a great speaker. So this is going to help all the youngsters to learn from him to how to do a proper ACL reconstruction. At the same time, I would like to welcome Dr. Miten, young and upcoming arthroscopic surgeon from Mumbai, and Dr. Prahalad is from another promising young surgeon from Madurai. So I hand over to Dr. Rajan sir to start this session.
Thanks, Sundar. Thanks for the nice, kind words. It's really my pleasure to moderate the inaugural session of IAS monthly meeting. Thanks to you. You both have done excellent work during the lockdown time. I'm sure a lot of youngsters are really benefited from all the Zoom meetings that you had all along. First, Sachin Tapasvi doesn't need any introduction. Everybody knows him. He's a world figure now, like like a best cricketer, Virat Kohli, like. So no, he doesn't need any introduction. It's a very nice topic he's going to touch upon. I'm sure many of you may not know that in the 90s we were doing only bone, patellar tendon, bone graft. Be it female or male, whatever, small patella, inferior, patella baja, patella infra, whatever, we are doing only that. And then came this hamstring tendon graft. And then we switched to hamstring graft. We thought that's a best graft, so easy to harvest, and no need for special instruments like electric saw, pneumatic saw, and things like that. But again, everything was not so good, because as we reviewed patients, the patients for whom we had done bone, patellar tendon bone, did extremely well as against the hamstring tendon. They eventually, some of them really stretched out. So it's a good topic, Sachin, you're going to tell us about. And can I hand over to you, Sachin, to give your talk?
Thank you so much, sir. I think it is indeed a very humbling experience and opportunity to speak in front of, the father of arthroscopy for India, Professor Rajan. And I'll start my presentation now. So essentially what we're going to be discussing today is that who gets which graft, and this is probably part scientific and probably what has been my surgical preference over the last couple of years of doing ACL reconstruction. So with passage of time, the graft strength starts decreasing. It is just probably least around the 3 to 6 month time. And around the 9 month time is when it starts ligamentization. And then that's when we get out to have a very strong graft. So the ideal graft, if I have to give my patient, should be easy to harvest, should integrate rapidly, should restore, of course, normal anatomy and biomechanics, should have fast recovery with minimum donor site morbidity. So how do I decide which graft do I use? And I think I use 3 parameters to decide. I decide based on the footprint dimensions. I decide based on the patient's age and his activity levels. And I also decide based on associated injuries. I've purposefully written availability here because sometimes a certain graft source may not be available. Before we dwell into my decision making, I think it's important that we look at the 3 main graft sources that are used for primary ACL, and all 3 of them definitely are much better with respect to load to failure and stiffness than the native ACL. What is another forgotten fact is how quickly does your graft heal, and a bone-to-bone healing should be possible in about 6 weeks, but soft tissues take about 3 months to heal, and if one is using an allograft, then it may very well take over about 4 months to heal or incorporate completely. Certain nuances of each graft source. The hamstrings, by far the most popular, very quick to harvest, is a plus point. And of course, you can use it with adolescents with open physis is a great plus point. But I think if you look at the downside, it may lead to hamstring weakness, which may be troublesome for some, especially the athletes. There's delayed graft incorporation, so you can't get your patient to go back to activity levels quickly. And saphenous nerve injury, though innocuous, does remain to be a problem that a lot of patients do discuss with us. Whenever I use hamstrings, I either use a 5 or a 6 strand hamstring graft, because your standard 4 strand hamstring graft usually will be less than 7.5 millimeters in diameter. And a lot of good meta-analysis have shown that the failure rate of ACL is high if your graft is less than 8 millimeters in diameter. And for this very reason, when your graft source is usually more than 28 centimeters, every single increase of diameter in millimeters that you get will increase the graft area by the square, which means that it will increase exponentially, thereby leading to a more robust graft. The BTB offers good advantages by way of fast incorporation and good diameter, but however, there are some problems associated with the same, especially with kneeling, tendinopathy, scar tissue formation, extensor lag, but these can be very well overcome with good physical therapy. There has to be a good way by virtue of which you harvest your BTB graft. There are various incisions that have been proposed. The one that I usually prefer is based over the distal 2/3 of the patellar tendon, and it is more to the midline. And by using sharp dissection, I like to expose and open the paratenon and then harvest my tibial plug first. Following the same, then I go ahead and then I harvest the patellar plug later on. And I always make it a point not to violate the fat pad, and at the same time use graft from the tibial side and pack it into the patellar tendon area. I felt that this, followed by good complete meticulous closure of the paratenon, helps in a good fast recovery, and thereby I feel that this should be a standard of care, especially when it's harvesting a graft. On follow-up scans, you should be able to demonstrate that your defect has well healed, and by virtue of this, a lot of the anterior pain that I would see previously has certainly gone away. The quad tendon gives you advantages of both the BTB as well as the hamstrings, where it can be used also in adolescents with open physis, and the quad tendon has the uniqueness of it being able, you can use it either with or without the bone plug. However, it does require special instrumentation, and the amount of or the length of graft that you can harvest can be limited by the length of the quad. If you do a side-to-side comparison of the quad tendon 10 millimeter graft with a BTB 10 millimeter graft, one can see that it scores over the BTB on various instances. The way you harvest is also quite critical. I've moved on to doing a nice horizontal incision now, about a finger breadth above the patella, going down with good sharp dissection, entry down, opening up the deep fascia, and then dissecting underneath the deep fascia over the fascia of your central quad tendon, which then allows you to have a good quad harvest. The use of an arthroscope, which is inserted, makes it pretty easy because that helps you achieve good dissection, and you can really open up the fascia above the quad. You can separate out the loose areolar tissue, which stays over the quad tendon, which will allow you then to put your instruments in properly. The purpose of today's presentation is not how to harvest the graft. So hence, I'm going to just fast forward this quickly. But the reason why I thought I should include this is because it's important not only to harvest a graft, but to harvest it correctly, because improper graft harvesting will definitely lead to problems, which will then result in a compromised outcome. So that's also very important. You need to also harvest your graft pretty well and pretty properly, which then helps you sort of get back to the proper results that you are interested in. The Peroneus Longus has got a lot of interest nowadays, especially in our Indian subcontinent. The major reason why it is getting popularity is essentially because it is superficial and it is easy to harvest and is long. But I think it should not be used as a primary ACL source graft, because we don't have any long-term studies on what happens to the biomechanics of the foot and of the ankle. And we also don't have long-term data about how the Peroneus Longus grafts work out in the long term. Though you can observe that if you do a side-to-side comparison with the hamstrings, it is definitely far better than the hamstrings. But I would still keep this as a reserve graft for those unusual situations where one needs to do collateral ligament reconstruction or some other additional reconstruction. Synthetic grafts, I think when you're using them, you can use them in an extra-articular mode, essentially as a standalone. But when you're using them inside the joint, you're better off using them as a hybrid, maybe the internal brace, or whether you're using them as a standalone graft per se. As a standalone intra-articular graft, they have failed quite miserably, and I don't think one should really explore the role of doing primary synthetic grafts inside the joint. Allografts are useful because there's no donor site morbidity, there's less pain, there's less surgical time, but they're slow to incorporate. They have a huge cost that comes with them, and they have a high rupture rate. So I think with this, I'll come to how I select my graft. And the first thing that I do before I harvest or decide upon a graft is to measure the footprint, because the footprint is going to give you a fair idea as to what sort of graft source you will require. And the reason why I say that is that if you have a short to medium attachment site, then your 5 strings hamstrings are a good choice, the 5 or the 6 strand, depending upon the length of the graft that you have. You don't want to overstuff the footprint. So you don't want to put a 10 mm graft in a footprint that is 9 millimeters. You want to achieve that sweet spot of 80%, which is very important. If you have a long and wide ACL attachment, which is more than 16, usually 18 millimeters or so, then you want to look at either doing a 10 millimeter BTB or a 10 millimeter quad tendon graft with or without a bone plug, depending upon your choice, which will then be the graft to go in this particular situation. What about age and activity levels? So not all patients are the same. On your left, you can see Sundar, who is a very active and fit person. On the right, you can see me, who is a couch potato, not doing too much activities. And though both of us may be of the same age and the same physique, I think the activity demands on both our ACL reconstructions are completely different. So how do I like to look at it? We like to look at it in 2 ways. You want to look at the young athletic sports person, and you want to really do a head-to-head comparison, whether you want to do an auto or an allograft or use BTB or hamstrings. And I think here's where this moon data is very useful. If you look at the Moon data, where they looked at almost about 2,500 primary ACLs with about 92% follow-up at 2 years, look at the three lines that you see there. The red line is the allograft, the green line is the hamstrings, and the black line is the BTB. So the allografts fail quite fast, especially in the younger age group. So the recommendation would be that don't use allografts in younger athletes. And of course, we know very well that age and activity have a strong risk association with both ipsilateral and contralateral ACL tears. So there are a lot of good level 1 to level 3 studies that demonstrate that allografts will fail, especially in younger people. And of course, amongst the allografts, there is variability as well. So you can have allografts which have proprietary techniques to those allografts which have got irradiation based on the current norms. And if you look at all of those together, you can still find that allografts will fail more than autografts, especially so the allografts which have had no radiation versus those which have been irradiated to less than 2.5 megarads. The next point that we want to look at is whether should I use hamstrings or BTB, especially in this young population which has females also in it. And if you look at more than 25 RCTs, one good Cochrane review, well, you can see that there's no difference between both of them. But then if you dwell deeper and start looking at various incidents of revisions with both graft types, then here you get the answers that the hamstrings are likely to fail 2 times more than BTBs, especially in high school and college athletes, especially so in females. And these people will have a higher risk of getting a contralateral ACL tear, which means that your treatment does not stop at just doing the surgery. You have to get them on an injury prevention program as well. So the predictors of failure for me, which I really look at for a BTB, younger age, lower BMI, and higher activity scores, my BTB is more likely to fail. A younger age and hyperlaxity, a high-grade pivot, a high-grade Latchman, the hamstrings is more likely to fail. So this is where, I make my choice as to what graft I should do. But mind you, if I do a BTB, there is a statistically significant higher risk of the contralateral leg getting an ACL tear, and the hamstrings has a higher incidence of the reconstructed ACL failing, which is what you must discuss. So in my practice, a BTB is someone who is young, who is athletic for all the reasons I've mentioned. A person who has a high-grade pivot shift gets a BTB. The athlete who has got recurvatum and hyperextension in the absence of any bony abnormality gets a BTB. The hyperlax individual gets a BTB. A person who requires a concomitant cruciate and collateral ligament reconstruction gets a BTB, both for the medial and the lateral side. And of course, when I'm revising, he gets a BTB. So I think if I look at a brief summary of these at-risk group patients, then I'm going to look whether they have hyperlaxity. If they are not hyperlax, I think based on the activity level, I'm going to give them a BTB, a quad, or a hamstrings graft. But if they have hyperlaxity and hyperextension, I'm going to be looking at the MRI, and I'm going to be measuring the thickness of the quadriceps tendon, about a centimeter proximal to the proximal pole of the patella. If the quad tendon is thick, which is more than 7 millimeters, they get a quad tendon. If it is thin, less than 7 millimeters, they get a bone tendon bone graft. So to conclude, I think all grafts have their own nuances. You need to learn to harvest your graft correctly, and you need to choose your patient wisely, because there does not exist an ideal graft, but there is no ideal patient as well, which is why we need to make a mix and match and use what you feel is best suited for your clinical practice. Thank you very much.
So thank you very much. There is an elegant talk as to how to harvest the graft and when to use what graft. Do you take any changes in the patellar articular surface seriously at all as far as the choice of graft is concerned?
So that's a great question. I think those patients which have, deep grade 3, grade 4 changes on the patella, I would go away from doing the BTB per se. Then probably, I think in those patients, I would use a hamstrings graft. But that is probably the odd patient which you need to really look into. A lot of these patients will have some chondral changes, grade 1, grade 2 changes, but not all of them are symptomatic. And I think one can very easily get away in such patients as well with the use of a BTB graft or a bone plug from the patella if the need be.
Does a patellar tendon length, does it help you in deciding as to what graft should be taking, especially in an athlete also?
So having someone who has got patella alta and has a very long patellar tendon, in those patients, on maybe 2 occasions so far, I have not harvested the tibial plug. I've just harvested the patellar plug, and because I had a very long patellar tendon length, I did not harvest tibial bone plug, and I used it like a hybrid BTB graft or a BT graft per se. But I think these instances of getting people who have extremely long patellar tendons is quite unusual. I have not seen so many in my clinical practice so far. Maybe less than a dozen times I've encountered them. And I feel that is something which is more the exception rather than the rule.
So my last question before I hand it over. And what about composite graft, Sachin? So anytime you had to harvest the hamstring and you found that it is not adequate, and then go for a Peroneus Longus or a lateral side of the quadriceps tendon graft, do you have any such experience on that?
All right. So ideally, I have been faced with a situation where I have accidentally amputated the hamstrings graft, or I have not got a good graft thickness per se. The gracilis has come out very thin. So instead of making compromises and trying to fool yourself or trying to convince yourself that maybe I'll add a quad tendon, I'll add, fiber tape, and try and do composite grafts and create a mismatch, I think in these patients, I have just given up on that graft source and harvested an alternative graft because I want to do one good operation, which ideally should last the patient for the rest of his or her life.
Right. Thank you. Samantha, you want to ask some questions, and any questions from audience, Sandeep? Samantha, go on.
Yeah, thing is that Sachin, is there patella baha is any way contraindication for patellar tendon harvest anyway?
Absolutely. So I think patella baha would definitely be a contraindication for doing BTB graft. Patella baha would also be a contraindication if it is not acquired. I mean, we are talking about acquired patella baha secondary to injury where there is scarring. I don't think I want to do surgery on that patient straight away anyways, because he's not going to have a good outcome. I'd rather first treat his patella baha and then offer him ACL reconstruction. If he's got bilaterally symmetrical patella baha and it is asymptomatic, then I would then move on to an alternate graft source.
Sachin, your minimal graft diameter, as you told probably in your deliberation, that 8 millimeter is the minimal graft. So do you every time you are happy with the 8, or you go ahead with the 9 and 10?
So the minimum that I would take for an adult is going to be an 8, because an 8 millimeter graft in a standard Indian footprint. So from whatever data I have, the standard ACL tibial footprint for a female is roughly about 9 millimeters width by about 14 to 16 millimeters in length. In an average Indian male, it measures about 10 to 11 millimeters in width and about 18 millimeters in length. So if you want to achieve that, that sweet spot of 70 to 78% of coverage of your footprint, you need a minimum diameter of 9. With that hamstring graft, the standard diameter that I usually get is 9, sometimes a 10, sometimes an 11. But just because you've got long hamstrings and you can make a 6-fold graft, I'm not going to make an 11, because that notch and that footprint has been designed by God to accept a maximum of 10. So just because I can make a larger graft, I don't want to make a larger graft there. But definitely there's very good compelling data that shows us that anything that is less than 7.5, especially hamstrings or soft tissue graft, is bound to fail and has got a 4 or 6-fold higher risk of failure than a larger larger diameter graft. Sorry.
David sir, have you ever used fiber tape in your ACLs?
Never. Never. Any questions from the audience? Sandeep?
Yes, sir. We have a couple of questions. I have already forwarded to Dr. Samanta.
Ranjit is there. Ranjit is there.
So I asked them, sir. Dr. Ajay would like to know that, sir, with a grade 3 pivot, if you are using BTB, do you add an ALL reconstruction?
So I think that's a question of debate now, and we really don't know the answer. We know that in patients who do have an explosive pivot, the first thing that you should see is look for the cause of the pivot. So be very careful and try and find out if he has a ramp lesion. Try and be very careful and find out if he's got a lateral meniscus posterior root tear. And of course, you have to treat the anterolateral capsular injury, whether you do an ITB tenodesis or whether you do an ALL reconstruction is a matter of personal preference. In my clinical practice, right now I'm running a randomized controlled trial in which patients who have a high-grade pivot shift are being randomized to 3 groups. And we'll be doing quantitative MR scans on them to measure their laxity. And those 3 groups are BTB alone, BTB with extra-articular tenodesis, and hamstrings with extra-articular tenodesis. So maybe in 2 years from now, I could have some answer as to whether it is needed or not.
Sachin, there is a question from Amit Joshi, doctor. How often do you come across the graft tunnel mismatch in BTB?
Graft tunnel mismatch.
That means the length mismatch, the way probably you have to just reverse the tibial tunnel bone part. Do you know?
Okay.
Okay, that part probably he's asking for. Yeah.
Okay, so there is you should ideally never ever get a graft length mismatch, because the moment you harvest your graft, you know the length of your graft. You know the length of your intra-articular portion, which is usually around 30 to 35 millimeters maximum. Your bone plug is anywhere around 16 to 18 millimeters. Your femoral tunnel that I normally drill is 25 millimeters, because the least length titanium screw that you get on the Indian market is 25 millimeters. So 25 millimeters goes in the femur, around 30-35 millimeters goes in the tibia, goes intra-articular, and whatever left has to be accommodated in your tibial tunnel. Now, if you see your ACL jig has a marking on the ACL on the side of your bullet, and on that bullet you can directly read off the length. So you can anticipate by doing simple measurements that total length of the graft minus femoral tunnel minus intra-articular is going to be the amount of graft that is going to be left. And when you change the angle of your ACL jig, you can change the effective length of the tibial tunnel, which is what I use. I will play around with it. If I know I have a graft left which is 35 millimeters, I'll change my angle and I'll see when I get 35 on my bullet, and that is the angle I will drill. So you should never waste your BTB graft. I don't think it is a good idea that you're wasting BTB graft, if at all.
Sir. Yeah, Prahalad is there waiting. Yeah, Prahalad.
Presentation, sir. Sir, do we have any alternative technique to harvest quad grafts, sir, if we don't have a tendon stripper, what we use?
So the quad graft, absolutely. I think you can do it the conventional way, where you make a 3-inch vertical incision, expose, just as the way you harvest your patellar tendon, where you make 2 parallel cuts. The same thing I think you should do on your quad tendon. Make 2 parallel cuts with your 15 or your 11 blade. Very carefully separate out. If you're doing a partial thickness, you will see the plane of fat between your rectus and your intermedius. Go in between that and you can release it distally. No problem at all.
So Sachin, he is asking whether without having the typical quad
exactly.
Tendon, whether he can use the other device like a tendon stripper. I think Prahalad, you are asking on that, no?
Yes, sir. Do we have any other open techniques? One what sir has told, and I think so. The only thing is we need not take the complete width of the quad tendon. We need to take a partial width, right, sir?
Yeah.
So that depends upon what you're trying to do, correct? So you need to be very well aware of what thickness graft you require. A typical quad tendon thickness will be around 7 millimeters, which is all that you need for your clinical practice, for your primary ACLs.
Okay, I think all the questions are done, David sir. Now your final
Excuse
comment.
me.
Samadha,
Yeah.
there are 2 questions in the chat box.
Okay.
Can you ask that questions?
Yeah, one question I think Dr. Jacob Haggis, he has asked, is the graft incorporation at tunnel graft revascular different in different grafts? I think Sachin has, during his lecture, he has already pointed out for the patellar tendon, it is 6 weeks, then 8 weeks for the hamstring and 12 weeks for your allograft. I think that question already been taken care of. Okay. Opinion of fiber tape, I think David sir has categorically told that he has never used. Sachin sometimes used those for if his graft is like 8 millimeter or sometime. I never use the fiber tape for my ACLs. And another question is, sir, what's the indication and patient selection for CQT over BTB? Sachin, CQT or BTB?
For whom?
Any ACL. What is your take on CQT or BTB?
So there's nothing black and white about CQT and BTB. So if I'm doing a primary ACL, I'm doing a female, and I find that her patellar tendon width is not adequate. You see these petite females with a very with a patellar tendons that is maybe 25, 26 millimeters in width. So in those, definitely I don't want to go ahead and remove like a 9 millimeter strip of the patellar tendon. I will significantly weaken it, and then I'll go on and do a quad tendon in that particular individual.
Maybe the last question.
Sir,
last question is
one
from
question.
Ranjit, yeah.
Yes.
Hello.
Yeah, Ranjit, go on.
Yeah, Sachin Bose, nice presentation as usual. My question is, what is your go-to graft or graft choice in young active athletes, and whether that graft choice remains constant for these kind of athletes, or you change from athlete to athlete depending on their need?
Absolutely. I think that's a very good question. So it all depends upon what sport they wish to play. If you have a soccer player who is playing, especially as a center forward, who's going to be running straight and down up the pitch, I would probably not touch his BTB. I would go to a quad tendon. If there is a soccer player who likes to cut on the sides, who's playing in the flanks, then I will not touch his hamstrings. I'll do a bone tendon bone. There is a badminton player. I would not be reluctant to take his hamstrings. To take his hamstrings. I would not like to touch his quad tendon, or I would not like to take his BTB because he needs to land and push off. Same is true in a basketball player. For a basketball player, I will not do a BTB. I will do a quad tendon for him. So you have to speak to them. You have to understand how, with what vigor and enthusiasm and zeal they want to pursue their sport. Within the sport, you want to find out what type of sport are they doing, what position are they playing, what are the frequently done activities that you have. So as a thumb rule, anybody who is doing a lot of side cutting, don't touch the hamstrings, leave them alone, because the hamstrings are good internal rotators of the tibia, so they need them. Look at alternative graft sources. In others who require straight line explosion, then you can take the hamstrings. That's not a problem.
Thank you.
Okay, I think all the questions are taken care. Sundar.
Yeah. Please, you can go ahead. Proceed with the next presentation.
IPS. Any final comment from your side?
Nothing. I think let's continue, please. I think
Yes,
all the questions.
yeah.
Thank you.
You can ask Miten to share the screen.
Okay, now over to Miten, the upcoming budding arthroscopic surgeon of India. Miten, carry on.
Yes, sir. Can you see my screen, please?
Can.
Yes.
And you can hear me, right? Okay. So this is a case history of 1 second, please. Okay. There. So I've just deleted the first line by mistake. It's a 34-year-old active athletic female with a skiing injury, non-contact, 4 months prior to our consultation. The acute scans and management were done in the first 2 weeks, and she has been on and off rehab since then. Her predominant complaint is instability. She has less confidence in almost all pivot movements. She says that she can neither run confidently nor turn directions. On examination, she has a normal BMI, a neutral alignment, no hyperlaxity or hyperextension at the knee. The anterior draw is similar to the opposite knee. The Lockman is a grade 1 or 2. I could elicit a pivot shift, but just about, and no joint line tenderness, no varus valgus laxity, and full range of motion with no restriction. These are her MRI scans, where what I could understand was that there seems to be an injury to the ACL fibers. That doesn't seem to be like a mid-substance cut through or an avulsion of the femur or the tibia. There is very little evidence to suggest there is very little bone marrow edema on the lateral femoral condyle or the lateral tibial plateau, and no evidence to suggest any anterolateral capsular injury as such, nor any injury to the MCL, LCL or the PLC. Now, the examination under anesthesia was that she had a firm endpoint to both her Lockman and her drawer, and the pivot shift again wasn't explosive. And under anesthesia, I could see that in extension, she had more of some translation, and in flexion, it was a little lesser. So should I continue with the surgical video, or I stop for questions?
No, Miten, you can continue with that.
So again on arthroscopy, a figure of 4, and you could see some peel off on the femoral side closer to where the PL bundle would actually be. It was there was a significant translation in extension, more so, less in flexion. And because I could check, I didn't have the video with the probe really tugging at the fibers, but most of the fibers seem to be intact. So I happened to clean a bit of what seemed to be the posterolateral bundle femoral footprint, and I could see there was enough space there. I proceeded further to harvest a semitendinosus graft. And this is just a video that demonstrates the graft harvest, and we had to triplicate the semitendinosus, got a length of around 25, and on triplication the femoral end was around 7 and the tibial end was 7.5. Meanwhile, on the arthroscopy front, I didn't actually get to measure the femoral footprint with a scale, but what I did was, when I used the reamers, I just tried to place the 6, 6.5 and 7 and tried to see if it was matching the footprint that I could see. This is a 4.5 reamer going on the bead pin, which was then followed by a 7 mm reamer on the femur. So here at this point, I put in the bead pin and then tried to check which reamer would be more appropriate. The 7 did at the end seem like probably maybe covering the entire footprint, unlike what I would have wanted, around 75 to 80%. And then on the tibia, we used a tip aiming guide and tried to find a point just behind the existing AM bundle. Just towards the end, when I wanted to get the reamer in, I had to pull the fibers of the AM bundle a little in the front with the probe, and didn't ream very aggressively. In fact, just pushed the reamer in, trying to protect as much of the native fibers as possible. And then we shuttled the sutures through. And we used an adjustable loop on the femur. Flip the button first and then shorten the loops to get the graft in. The graft was then cycled through a range of motion. It was very difficult to check if there was any impingement in deep flexion. The extension, of course, was free because the AM bundle wasn't touched at all. And we used interference through screw fixation on the tibia. There you can see the final picture, and I tried to tug at it just before this part, and you can see that there was hardly any translation then at the end of the construction. So should I stop now or then go ahead with a review of the literature?
Finish your presentation, Miten.
So a few take-home points that I took from reading about this, that partial ACL tests are probably seen by us in around 5, 10, maybe 15% of our cases. The clinical results of selective ACL augmentation, if we find an indication for them, are at par with standard ACL surgery. An intact PL bundle probably leads to a higher rate of a negative pivot shift. The diagnosis for us to lead to a treatment of selective ACL bundle reconstruction must consist of clinical exam, MRI, and examination under anesthesia, and a correlation of all these three. For the femur, Sonnery Cotte has spoken about trying to use an outside-in technique, because maybe if you use an accessory AM portal and drill, as we just showed, it leads to some loss of the native fibers. And there's a nice algorithm published which talks about how and when to offer an ACL augmentation for a selective bundle. So you look at the laxity compared to the opposite side. And if you have a knee that's not showing a lot of AP laxity and a negative pivot shift, then you'll end up try to conserve that patient. If you have a positive pivot shift in the absence of a significant draw or a lockment compared to the other side, and the patient is very young or has, of course, meniscal injuries and stuff, then you can offer surgical treatment. But other than extremely active professional athletes, most of those also would be conserved. And if you, of course, have an anterior drawer and a lockment that's significant or a great pivot shift and high risk, then that directly goes into surgery. For all the patients that are conserved, if after 2 or 3 months, if they persistently complain of instability, and then you have a case where you have a positive pivot shift and you may or may not have AP laxity, then you can correlate your MRI, your examination under anesthesia with this clinical reading, go inside, look at your ACL fibers and try to find if they are morphologically intact, look intact, and then probe them and tug at them to find out if they are functionally intact. And if you find anything intact, then you keep it there. And whatever is missing, you try and recreate only that. That's it. Thank you.
Yeah, this is a great concept to preserve as much native ACL bundle as possible. Did you mention anything about the keyboard's position, Miten?
So what's published talks about the cabot's position, the figure of 4, giving us a better idea of the PL bundle. Also the fact that it stretches out in the figure of 4. So if there is a rupture, then that's the best position to try and look for some bleeding or some peel off at the femoral end.
Okay, the only downside is sometimes trying to preserve the native ACL. You your tunnel may go a little non-anatomical, or in the end of it all, after making tunnels, you find that what you really wanted to preserve is torn. I don't know what the other's experience is. In idea, Samantha, Sachin?
Yeah. I think doing the doing the PL bundle, sometimes there are too many issues are like that. You can overstuff. If your graph is more than 7 millimeter, then it is overstuffing is a question. And sometimes I completely agree with my arthroscopy guru, David Rajan sir, because he is the person who taught me how to hold the arthroscope in my beginning of my career. So whatever he is telling, like the figure of 4 position, and also the way we do the PL bundle, probably it is better to do the outside in technique. Who is for Sachin? What's your take on the outside in technique for the PL bundle?
I think outside in for me as well.
Yeah, Sachin?
So I think as regards isolated ligament reconstruction, ligament bundle reconstruction, I have gone away from them. There's not too much compelling evidence now that one should be doing, isolated AM or PL bundle reconstruction. One of the reasons being is that even if you do an isolated PL bundle reconstruction, your AM bundle has also sustained trauma. At the same time, it is more likely to have, the collagen is more likely to be injured. So in these patients in whom you see that, a lot of your ACL is intact, I prefer to do a standard ACL reconstruction, but I do a remnant preservation, wherein I try and preserve maximum remnant as much as possible and try and take your graft through the remnant. But I would continue to put my tunnels at the anatomic position and do, standard ACL reconstruction with remnant preservation.
David sir, there one question to you, sir, as because you are the teacher for all of us. Thing is that, is there any recommendation how to put what is the ideal point for the PL bundle reconstruction? Any literature or your experience?
PL bundle.
PL bundle, isolated PL bundle.
No, you have to trace the torn PL bundle if possible, and I'm not sure what you are talking.
No. In literature, like people tell that it should be 6 millimeter below and 30 degree posterior to the AM bundle. Do we follow that, or we just take the surface fibers where it is torn and go ahead?
No, what I would go whatever is torn and go that place, and retaining the AM bundle as intact as possible.
Sachin,
another probably you might be answering the other way, because I have seen people, whoever is doing the isolated PM bundle, they are doing the femoral tibial your entry at the middle of the footprint.
So if one wants to do a the classic PL bundle reconstruction, then you need to have a graft diameter which in the average intent should not be more than 6 to 6.5 millimeters, which means that you end up taking either a 2-strand Semity or a 2-strand or a 3-strand gracilis, and you have to obey the correct tunnel positions, wherein you have to have your posterolateral your PL tunnel on the tibia, which is more posterior towards the PCL, and on the lateral flush with the lateral tibial spine, and then you have to come right in front of of your ACL footprint, and again tension it, not like how you would tension your AM bundle, but tension it differentially at about full extension.
Full extension, yeah.
Okay, my question is to Miten.
Yeah.
So, what is the patient? What is the did the patient have instability, and what made him to decide to do a PL bundle reconstruction in this case? How did he diagnose the PL bundle is there before the surgery? Only after arthroscopy, or what clinical finding, clinical compliance, or signs made him to do this PL bundle? Miten?
My clinical diagnosis before going in for surgery was that this patient likely has a partial tear compared to a complete tear. This was on the basis of not the complaints per se, but the clinical examination that pointed more towards a lesser injury, because she had a very little pivot, almost no anterior drawer, and a grade 1-2 Lockman.
Did he have any rotatory instability clinically? I mean, when he complained about that rotatory instability?
So she said that she found it difficult to turn simple directions. I could probably take that as a marker for some rotational instability, but she couldn't run straight as well, which wasn't explained, because if she couldn't run straight means maybe she was having difficulty with controlling AP as well.
Yeah.
So the plan was to go in, have a look at the fibers, and probably go in for a conventional ACL reconstruction versus a remnant preservation versus something that I just did. What I saw under arthroscopy was that everything in the direction and region of the AM bundle seemed to be absolutely intact morphologically, though functionally there was some translation and you could see those fibers. There are two studies, one in 2016 by Bertrand Chonnery-Cotte and the other one in 2018, and I think again by Philippe Colombe and his group, that spoke about if you do a remnant preservation surgery in this case, or you keep what is morphologically intact, and you try and replace or reconstruct what doesn't exist, the functional outcomes, the return to sport, and everything is at par. There is no difference of proving one thing superior than the other.
Miten, thing is that when you read this Chonnery-Cotte paper, probably from that we have all been referring to, they usually fix the tibia first and do the femur second.
Yes, sir. But why should that have a difference on the results?
No, because you did in different way, because you have used the tightrope on the one side and femur, and then you've done the tibia. So just for the sake of the question, because whatever they India series they have done the tibia first and they have fixed the femur from outside in with interference screw. Is there any how you I think it's not going to change anyway.
I hope that it doesn't change in any way, because all that matters is that we get the footprints right and tension it. So I had one difficulty during the surgery where I didn't know whether the tip aiming guide on the tibia had to be taken from the side of the lateral meniscus or from the side of the medial meniscus. On the mediolateral front, if at all you're trying to reconstruct a posterolateral bundle, is it right in the center, more medial or lateral, and which way is it better? If I can get some guidance on that.
I think in that paper also they have not commented anything on the tibial side, because they are more or less concentrated on the how to do the femur outside in and how to fix from the tibia femur from the outside in technique with the interference screw. As because probably you have done the correct way, because it is more or less middle. That's why some people are doing at the mid stump on the tibial side. And thing is that as because you have used the tightrope, probably you have one option still left. Even if you have done the tibial side fixes and still you can retighten on the femoral side.
I think it's aimed posterior to the tibial footprint and slightly in the lateral entry point where the posterolateral entry point should be there. I think Miten had showed that video also. The aimer has placed posterior to the normal footprint where that entry point was created.
Yeah. So nice one, Miten.
Thank you, Miten.
Thank you.
Good presentation.
Thank you for the opportunity.
Good.
Yes, Prahalad.
Shall I share? Yes,
Please.
Good evening, everyone, sir. Sundararajan.
We can hear you.
In fact, I'm presenting a couple of cases of anterior shoulder dislocation. So we all, sir, is it visible, sir?
Yes.
Yeah, okay, sir. So I'll be presenting a couple of cases and also a series of our experience. So anterior shoulder dislocation is a common condition we all have in our practice, but the pathomechanism, the treatment modality is little different in elderly patient. So this is my first case. She is a lady, 60-year-old with no comorbidities. In fact, before this injury, this lady presented to our outpatient with a full thickness cuff tear, for which we had suggested her a arthroscopic cuff repair. So the patient took a while, and then she sustained this domestic fall at home and sustained an anterior shoulder dislocation and presented to her ER. So where we did a close reduction in the ER and then asked her to, gave her a sling and medications and asked her to review after 1 week. So then on examination, we found that it was quite unstable and painful. So we asked her to do another MRI. So, and then she presented to us with MRI, which shows the following findings. The pre-existing cuff tear was there, and also there was an Hill-Sachs lesion was seen, and also an anteroinferior capsulolabral lesion was also seen. So, and then we suggested her that she undergoes the procedure. So this was the kind of instability she had under anesthesia. So we did a scopy of her, so which confirmed all the MRI findings. She was having an anterior capsulolabral lesion. So there was a partial subcap tear, there was a supraspinatus tear. So we decided to do a Bankart repair for this lady. So we used a double loaded anchor at 5 o'clock position and did a good capsulolabral repair. So we used another anchor at 3 o'clock position and had this top block kind of anterior capsulolabral repair. We also did a biceps tenotomy for this lady. And then I do a mini open cuff repair. So I just did a mini open procedure and did a double row cuff repair for her. So actually this patient had, we did surgery just 3 weeks ago. So this is a patient, we did similar surgery around 1.5 to 2 years back. So this gentleman had a bony Bankart, so with the cuff tear. So we did a similar procedure for him, and in fact, since the fragment was big, so we fixed his bony Bankart and did a mini open cuff repair. And this gentleman is having an excellent outcome. He never dislocated after that. So I'll come to my second case. This gentleman is a 65-year-old who was a pylon rider who fell from the vehicle and had a fall, landed on both of his arms. So he sustained a left-sided distal radius fracture and right-sided anterior shoulder dislocation. So this again, he was reduced under anesthesia, and the distal radius was percutaneously close reduction and pinning was done. So we gave him a sling and asked him to review after 2 weeks. So this patient was absolutely not able to do any abduction or active movement on the follow. So we asked him to get an MRI done. So this MRI showed that there was a full thickness supraspinatus, infraspinatus, and subscap tear, and even the biceps tendon was subluxated. So, but the labrum here was appeared to be intact. So we again took him for the procedure. So we saw that his labrum was intact here as opposite compared to the other case, and he had a full thickness cuff tear, pan cuff tear. So I do a mini open repair. So I was able to appreciate there was a massive cuff tear. So I did a double row repair, cuff repair. And this patient is just 3 to 4 weeks post-op now, and he is now able to do active movement. This is another similar case. He is a father of our pediatrician who had again pseudoparalysis kind of thing. So I could not get his MRI. So I just asked him to share his present pictures. So he is doing excellent. So in our series from 2018, we had around 15 cases of anterior shoulder dislocation over the age of 50 years. So there were 5 patients of 50 to 60 years age group. 6 patients were between 60 to 70 years of age group. There were 3 patients who were between 70 to 80 years and 1 above the 80 years. So we did close reduction alone in 6 cases. Cuff repair was done. Cuff repair alone was done in 3 cases. Cuff repair with a stabilization procedure was done in 4 patients. 2 patients had a GT avulsion fracture, so we did a fixation of the GT fracture. So these were the cases. So when I went through the literature, we had seen that these have the shoulder dislocation in elderly individuals have a very low recurrence rate, which up to 31%. And they have shown that they are most commonly associated with fractures, neurovascular injuries, and cuff tears. So older the individual who is not able to lift arm following an anterior shoulder dislocation, they say you suspect a cuff. Rapidol have again similar findings. So in their series of around 29 patients, they have 31% recurrence rate, and they also showed that the main pathology is in the cuff. So Sang Shin has given a good algorithm. Basically, we also do follow this in Arthroscopy and Orthopedic Sports Medicine Journal. So any shoulder dislocation, do a close reduction and give them a sling and review after 1 or 2 weeks. If the patient is symptomatic, is not able to lift his arm or have again a feeling of insecurity, so it's better to get an MRI done or ultrasound if you have a good sonologist. So then based on the pathology, you can plan the procedures. And they have again shown that early detection of these injuries with appropriate treatment had an excellent outcome. So this by Wayne Chatlier et al. Have shown that the rotator cuff is the main pathology in older individuals as compared to labrum in the younger, and surgical management can prevent morbidity associated with recurrent instability. In patient older than 50 years of age group with shoulder dislocation have a massive cuff tear, and treating them will have an excellent outcome. So Gumina et al. Have a very vast series published in JBJS. So out of 545 cases of anterior shoulder dislocation, 108 were over the age of 60 years, that is around 20%. And they followed up with around 7 years. And the axillary nerve injury was seen in around 9% of patients, which recovered in due course in all the patients. And the recurrence rate was around 22% in their series. So 58% a patient had cuff tear and only 16 were operated. So 11 underwent cuff repair, and in 5 patients, additional stabilization procedure was done as in our series. So the take-home message here is the anterior shoulder dislocation in elderly subject is more common than generally believed. 20% suffer redislocations. 60% of patients have cuff tear. The shoulder, the surgery may be needed to repair the cone cuff or to stabilize the shoulder based on the MRI and arthroscopic findings. And all patients do well if operated, except those with multiple redislocations who have undergone only cuff tear repair. So it is very important, if there is a redislocation and if there is a labral tear, it is very important to address both the pathologies. Thank you, sir.
Thank you, Prahalad, for your nice presentation. Any question or any comment? David, sir? David, sir, you have to unmute yourself, please.
Oh, sorry. Good series of cases, Prahalad. And it's very clear that on the elderly patients who get dislocation of the shoulder, almost always have a tear of the cuff. And tear of the cuff has to be primarily taken care of. Very often you can leave the Bankart lesion alone and the patient does well. Is there any literature to say that when the tear is when exactly do you have to repair the Bankart lesion? Do you have to repair the Bankart lesion all the time? So what do you say, Samantha?
Yeah. Okay.
No, every time, basically there are three sort of combination, like it is classic rotator cuff only the Bankart, the cuff is okay. But if it is more than 60% of the redislocation or dislocation, they are having the cuff component. So whenever both the components are there, you have to go ahead with both the components.
Yeah, that is the reason I presented both the cases, sir, so that they had both the pathologies there. So whenever there is a Bankart tear, so it is always better to address. And they have even the article by Gumina et al. And they have also shown that whenever there was a recurrent dislocation and only cuff repair was done, they had not very satisfactory outcomes.
Prahalad, can you unshare your screen so that now I think it is now, yeah.
Yeah, Prahalad, I think it's a very controversial subject because many believe that in elderly patients, if you have a massive rotator cuff tear, if you just stabilize the cuff repair, the patient will have a good functional range without any much recurrence. I think still it's debatable. People say that if you have a more active older patients, I think the expectation of the patient, the satisfactory outcome, what they meant is not just recurrent dislocation. Now, I think that is the main criteria. If the older patients, active patients who are doing sports, then these patients may require a capsular labral stabilization along with the cuff repair. Otherwise, I think the less active older gentlemen, I think massive cuff tears, I think cuff repair alone can stabilize the shoulder too. Yes, Sachin.
Yes, Sachin is there. Yeah.
So I have one question here. Is that there is another injury pattern that we see, especially with shoulder instability in the elderly. A decent number of them, because of the quality of bone, also have a significant bony Bankart, which at times becomes quite difficult to fix arthroscopically because of poor bone quality. So in that situation, what sort of treatment proposal would the house like to give in these situations? Anyone can comment, please feel free.
Sachin, you are talking of the bony Bankart?
Yeah, we're talking about bone loss after a primary or the first or the second shoulder dislocation in an elderly, which at times is quite more than what you would get in a younger patient. The reason being, a lot of these patients will have significant loss of bone quality, especially in the glenoid and the humeral head as well. So in these patients, how many of you would consider doing a primary Latarjet procedure to counteract that instability if they have bone loss, which is say 10-15% of the glenoid?
Yes, Sachin, the thing is that the question you are asking, that the bony Bankart we in the elderly group along with the cuff tear, the literature are very, very scarce on this issue. So main thing is that whatever literature we got for the more than 60 years dislocation or redislocation is combination of Bankart along with classic soft tissue Bankart along with your cuff. So I think David sir, from your clinical experience, can throw some light on that.
The bony Bankart in dislocation in the elderly is rather rare. It's usually soft tissue Bankart, and you don't have to touch that at all. You just repair the cuff. They do very well.
Yeah. Thing is that usually they heal well. Even if you immobilize, basically they heal well and they become stiff.
Yeah, Samadha. Yeah, I think that's what the same point I want to make. As David Rajan sir said, in elderly patients, there are low velocity injuries. We hardly see any bony Bankart in a cuff tear. Usually we see the soft tissue lesions. Even if you have a bony Bankart, I think they tend to heal very well. Even in younger generation, the literature doesn't support only bony Bankart repair, because there's equally good results if you treat conservatively. Even in younger patient, it shows very good results. So I think in elderly patients, even if it's a bony Bankart, still we can go ahead, do only the cuff repair. They do very well.
Yeah, Prahalad, another one thing, probably you have covered everything. Another one thing is the terrible triad of the shoulder. Like you get the dislocation, you get the cuff, and along with that, you get the axillary nerve palsy. So that is the terrible triad. Have you ever got this terrible triad, like you don't get the suprascapular or the radial nerve palsy. This is the other two components for the terrible triad.
More
But
than,
yeah, but
more than axillary nerve, you can have a brachial plexus injury also.
Yeah, that's I'm taking. It is terrible triad is the brachial plexus, Bankart along with the rotator cuff.
Yeah.
Sir, there is an incidence of around 9%, sir, particularly in the elderly population, and also we in our series we did not had any case of such injury, sir. But in the literature there is an incidence of around 9%, and most of them have recovered over 12 months of time.
Yeah, that is the best part of the story, because if you get the axillary nerve with your terrible triad, usually most of the time, even in the literature, they are telling like 100% the axillary nerve recovers within 3 to 6 months time. Yeah. Any comment from any other faculty? Ashutosh.
Unmute, Ramakanth.
Ashutosh also. Tanmay is there. Our past president. Pratik is also there. Pratik.
One question for Dr. Prahalad. Was subscap also repaired in your first case? I think was it torn in the?
No, sir. First case it was just a partial tear, sir. So I did not repair that, sir.
Okay, just with the permission of David, sir, I am just going back to Miten's lecture because one question I left. Sorry, because Sujit Jose is a very learned faculty. So he has asked the question, when you do the femoral tunnel, if you do in flexion, do you R on the front side? That means my question is that when you do your femoral tunnel in flexion, do you erroneously put your femoral tunnel on the anterior side? That is Sujit's question.
My understanding is that in deep flexion, the posterolateral bundle footprint is closer to us.
Okay, so you do in full flexion. Okay, understood.
Yeah, Samanta.
Yeah.
Can I comment?
Yeah.
On the second case, the shoulder, I agree with Dr. David Rajan and everybody's experience that the bony Bankart are rarer. So doing just the soft tissue and leaving the bony Bankart, in my experience, also have been fine. And on a couple of occasions, we've just done a bony Bankart, just like a soft tissue repair, and they have gone on to heal well. So they're in the elderly population. Secondly, coming to Mithen's lecture, the first one the case he presented, there was one comment from Sachin about that he has gone away from doing isolated bundle repairs or reconstruction, though we still continue to do. And as Sachin said that he would go do a standard ACL, and as had been commented earlier, if you go, Sachin, do a standard ACL, we almost end up removing most of the bundle there. And then the remnant left is not really very much connected. And do you feel preserving that kind of a remnant, does it help in the ACL post-operatively?
Rather than putting
asking me?
Yeah, Sachin.
He's asking when there is a PL bundle has gone, still you go ahead and remove the most of your anterior bundle and do the regular ACL reconstruction.
So I think the key here is that you should not and you should never compromise your tunnel position. And the reason being is that the number one reason for ACLs failing is poor tunnel placement. So just because you see that remnant and you want to preserve that extra bit of soft tissue, so I would not ever err on my tunnel placement, because I am leading myself towards an early failure by erring on the tunnel location. So if there is any collision which I need to remove to see the correct anatomical footprint or the area, I think it will have to go.
Okay. And for the normal reconstruction, do you preserve the stump, or do you I saw you just generally remove to look at the footprint, you remove all that stump, obviously, to get to look at.
Sometimes when there is hardly any stump left, you take it off, but I don't aggressively debride the stump as what one would do previously. We now have, better ways of looking at the footprint without actually removing everything that surrounds it. you can, you have good aimers, you have elbow aimers, you have tip aimers, and you always have a ruler. So your ruler, when you place it along your footprint, it can tell you whether you are, too far deep, too far shallow, whether you're too medial or too lateral. And I think that can give you a very good guide regarding the same.
Sure.
Okay. Terrance, D'Souza, yeah, D'Souza is there, yeah.
Sir, Sachin sir, one question you had asked about this non-operative treatment, which Sundar sir also commented. So there was a study of a large antro-inferior glenoid rim fractures with a mean age of 53, which we discussed last time. They have conservatively treated around 26 patients with a follow-up of almost 6 years with a very good non-operative outcomes. Conservatively treated after first-time dislocation. But this was without a cuff tear.
Yeah, D'Souza, the thing is that if your bony bankard, most of the literature also supports that if the fragment is less than 10 to 15% of your this thing, you can still conserve and you can have the best of the results. But 15% is the cutoff. In some literature, it is 10% cutoff. But in I think if the consensus goes, we can take 15% as the cutoff, because we had a great discussion on what is the ideal cutoff for the bony bankard, even in the youngs.
I think there is no much cutoff for the bony fragment. I mean, you saw for the bone loss, for the lethargy, it's okay. But when you have a bony fractures, like a bony bankard, actually the bigger the fracture, they heal very well. Unless they displace so medially, then if it is not, even if this a big fragment, like 30%, what you are saying is a 15%, even a 30% of fracture, if it is not much displaced medially, still we can treat conservatively, they heal very well. I remember even the Sanjay Desai presented in a panel discussion. I don't remember one of you in Mumbai, and it showed an excellent healing with the 3D CT reconstruction after 6 months by conservatively treated glenoid fractures. So still there are very good papers in the literature to show even the big glenoid fractures, they heal very well.
David sir, your comment please, because you are the master on that.
Thanks
no,
for that.
Whatever you will tell, we will take everybody will take that.
No, basically it have to know whether it's displaced or undisplaced. If it is undisplaced, and then you can treat conservatively. If it is displaced, in my opinion, I have to treat operatively.
But any percentage-wise criteria in your mind, sir?
I can't tell you. Sorry.
Okay.
One question, Sachin sir. Do you do primary lethargy in any of your cases? As to comment
after the first dislocation?
Oh no, any of your cases, or what is the indication for primary lethargy? Older position.
First dislocation.
Yes.
He is first time dislocator.
In the
elderly patients, I think that's what he meant. In elderly patients with the big bony fragment, will he do a primary lethargy? That's what his question.
Ramakanth, you are asking for the young people or the elderly. Can you just
elderly, sir.
Elderly is more than 60.
Yes. The elderly, Ramakanth, we are saying that in the elderly, you don't come across bony bankard. How many have you seen bony bankard in the elderly?
No, we haven't seen, sir. Actually, in our institute,
that doesn't happen, doesn't it?
Case for a neglected dislocation with anterior bone loss. So that was a good case.
That is a young patient.
No, that is a different issue, Ramakanth. It is basically neglected, basically locked anterior dislocation or whatever. Then you basically there is a because there is a impaction of the bone. It is not like your bony fragment. Am I correct, Sachin?
Yeah, that is a different scenario.
The point of bringing out this discussion is to highlight the difference between the injury pathoanatomy between the young and the old, where you can see that what we commonly see in the old with bone injuries is not that frequently seen in the elderly.
Yeah.
Sir, a very valid point. So I'll just, the first case which we saw that it was so grossly unstable, sir. Initially she came with cuff tear, we suggested surgery, then she dislocated and it was like grossly unstable. For that case, will the forum do a bankard repair with cuff tear or cuff repair alone, sir?
Still, I do only cuff repair because that patient is around 65 years, I think, what you had told. Yeah. So still we do. I do only cuff repair.
Tanmay, any comment? Any question from your side, Tanmay?
Unmute. Tanmay.
No, I think I would even go for only the cuff repair, because they usually, these elderly people don't re-dislocate. Literally, they usually don't do. I haven't find. I mean, so better just to treat the clinical problem which would we expecting to happen. So that's, I agree with Dr. Sundar and Dr. David Rajan sir that I think the cuff repair should be sufficient.
Okay. If there are no further questions, can I ask David Rajan sir to conclude concluding remarks?
Yeah. Thanks, Sundar and Inda, for asking me to chair over this session. There's an excellent feast of arthroscopy knowledge we gained for the last couple of hours. Sachin's talk, as usual, was par excellence. And thank you, Sachin. And Amit and Miten and Prahalad, your case reports also very good. Good discussion. Thank you very much. I wish you all the very best for all your future meetings, Sundar and Inda. All the best.
Thank you, sir.
Thank you, sir. Thank you.
Thank you.
Thank you.